afternoon. Oh, you got to do better than that. I know it's right before lunch, but hold on, hold on. So again, thanks for the opportunity to be here. Thanks to the organizers. As Sandra said, I'm a senior program officer with the Kresge Foundation. For those of you that might not know Kresge, you might know Kmart. Raise of hands. Okay, that's how our foundation got started, got our fortune. And we're headquartered in Troy, Michigan, which is a suburb of Detroit. And really our mission is to advance opportunities for low-income communities in America's cities, but doing that by addressing systemic and institutional racism and trying to bring equality and justice. So I have an opportunity to sit in our environment program where we work on building climate resilient communities. And a part of that is realizing that we can't just work on environment, but I think a lot of the themes that are coming out here today is that we have to work across programs, across sectors. And so we give about $160 million in grants annually through our 6 programs around arts and culture, human services, health, education, environment, and I'm probably going to miss one, but please check out our website for more information. So, you know, in this room we have practitioners, advocates, researchers, students, moms, dads, people, and I think the one thing that we all have in this room is the power to change urban health. And it's because I hope, and I'm making a strong assumption, that we care about people. I mean, that is the thing that threads us together. And when I think about the people that brought me into environmental and public health a long time ago, I think about my grandparents. I was their primary caregiver during their 80s and 90s for several years, and realized that there were systems in place that were not taking care of them, public health systems that had kind of left them and pushed them to the side. And so as I think about the lessons that I learned, I think about the impact of bad urban design, okay, that already are making communities that are already challenged even more challenged. And our speaker, Helen, is going to speak to urban design and urban planning and the importance of that. When I think about the multiple levels of risk, from micro to macro, that my grandparents faced, again, directly impacted and would directly impact their prescription for health. Dustin is going to touch on that for us in his talk. When I think about the solutions that were offered, and the solutions that were not really informed by my grandparents or by the communities that they were in, the importance of community-informed solutions is so critical. And so both Barbara and Angela are going to speak to that in their talk. And the thing is, if we don't actually institutionalize our learnings and our solutions in a way that we can use them and replicate them, this is all for naught. And so Oliver and Carlos are going to speak to the importance of health systems and other approaches to help us with this institutionalization. So again, we have an awesome group of experts that are going to come to the stage. I'm going to shut up right now and offer you, again, this panel on approaches that is going to dig a little bit deeper in the 7 minutes as much as we can. And we'll start with Dustin, and then it will be followed by Barbara and Angela, then Carlos and Oliver. So Dustin, come on up. Thank you.
I don't know how to go back, but that was the green button. Okay. My name is Dustin Duncan, and I'm an associate professor at NYU. I first want to thank Sandra, Catherine, and David for the invitation. And I want to thank my co-authors who really helped push me to write this chapter, especially my senior co-author, Basile Shea from INSERM in Paris. Okay, so I'm going to talk about multi-level perspectives to urban health. First, I'll provide an organizational framework. Then I'll talk about methodological approaches. I'll then talk about highlights from research, just one example as related to sleep. Then I'll talk about challenges or limitations, and finally ending with opportunities. So this is a quote from Bill Schrank, who's the Senior Vice President and Chief Medical Officer of CVS Health. He said, "Health happens in between visits to the doctor." So he happens to be a physician. I'm assuming he understands that individual factors matter, and certainly the healthcare delivery environment. But it seems to be implying that there are other levels that influence health, things like the workplace, the grocery stores you go to, the places you worship, as well as your home environment. This is the social ecological model, which has been touched upon in some of the talks before, which was originally articulated by Uri Bronfenbrenner And it's really highlight this model as it related to human development. It highlights that there are many factors or levels that can influence health, including the individual level, the network level, the neighborhood or community level, and finally, the public policy level. So let's start off with the individual level, which is the first level, and where the vast majority of research has been conducted. It depends primarily on biological, cognitive, perceptual, and behavioral factors associated with acquisition and risk for transmission. What about the second level, the network level? It includes social networks, family networks, sexual networks, and drug-using networks. You can imagine that there are many mechanisms that can link networks to health, including social support and social capital. Now the next level, the community level, which is the level that my work predominantly focuses on. It determines access to prevention resources, treatment and care services, as well as other type of resources that are useful to maintaining health, including healthy foods, parks, and sport facilities. It also includes physical exposure, such as air pollution and noise. And finally, the fourth level, the macro or public policy level. It includes overall indicators of economic performance and economic crises, and the policies implemented to intervene on population health that can either promote healthy behaviors or decrease risk, such as the soda tax in New York City. So there's a wide range of methodological approaches from my perspective to think about multi-level perspectives, including the first being a regression approach, looking at, for example, one level in a social ecological model, or looking at more than one level. So for example, using classic multi-level models to look at the individual as well as neighborhood level to isolate what's been quote unquote dubbed as the neighborhood effect. I'll provide some examples looking at each of the levels, especially the first three, as relates to sleep. Why sleep? Perhaps not surprising, like diet and physical activity, sleep is immensely important to our health. It's been associated with a wide range of health conditions, especially cardiovascular conditions, such as obesity, type 2 diabetes, and hypertension. Also, sleep is interesting because we see this social gradient in sleep. In fact, we see that there are large disparities in sleep. For example, where sexual minorities are more likely to exhibit poor sleep patterns. So at the individual level, there's been some work looking at hormone treatment and sleep. At the network level, there's been some work looking at family dynamics and sleep. And there's been some work at the community level looking at how community structures such as neighborhood safety may relate to sleep. So this is a study of over 150 transgender men and women within Germany, and they found that sleep quality was disturbed for both transgender men and transgender women when receiving hormone therapy. This study looked at family dynamics and sleep among a sample of sexual minority youth. And they found that for young sexual minority women, less favorable relationships with both their mother and their father and related stress accounted for 32% of the association between sexual minority status and having greater sleep problems. For sexual minority men, less favorable relationships with their father, but not their mother, and related stress accounted for 27% of the same association. This is a study that our group conducted where we found that perceived neighborhood safety was associated with poor sleep quality, short sleep duration, and having sleep problems among a sample of sexual minority men. For example, people who report living in neighborhoods that are unsafe report being 2 times more likely to report having problems staying awake in the daytime. There's also another approach which has been touched upon today, such as agent-based modeling. In brief, agent-based models are computer representations of complex adaptive systems, and they've really gained currency as one of the flexible approaches to understanding or modeling complex environments. So modeling interactions between agents and environments, as an example. I wouldn't have called this limitations as I put it here, but I really frame it as challenges. There are challenges with every approach, including multi-level approaches, such as there being complex and diverse methods. And finally, the data structures. Obtaining data for a wide range of data structures at each of the levels could be difficult beyond self-reported data. And I'll give you an example of one thing that we're doing to overcome that. In one of our cohorts right now, we're collecting network data via Facebook to come up with an objective measure of one's network to also approximate a sociometric network. But there are opportunities. In the chapter we wrote, a multi-level perspective leads us to a more complex understanding of health, understand influences on health, but it also lays the foundation for testing the impact of interventions in the environment, such as urban planning initiatives, on multiple health outcomes and health behaviors. Thank you.
Okay, I'm Barbara Israel, and I'm delighted to be here, and thanks to the organizers for inviting us, and a special delight for me to be co-presenting with my long-term friend and community partner from Detroit, Angie Reyes. We're going to try to stay within our 7 minutes and follow. There were sort of 4 questions that Jalone organized this panel. Really appreciate that, and asked us to address. So starting by talking about what is community-based participatory research. And giving a definition, it's a partnership approach to research that equitably involves diverse partners in all aspects of the research process. And that emphasis on all aspects of the research process, not inviting people to participate after the researchers already decided what the research question is, but involving the community very early on to decide what is it we're interested in researching and how are we going to do that process. It equally involves, it enables all partners to contribute their expertise, share influence, decision-making, and ownership. Ownership here is really an important consideration. It's about power sharing and sharing data and throughout, again, the entire process. It enhances understanding of a given phenomena, and it also applies knowledge gained to inform interventions, policy, and social change to promote health equity. So it's not just about collecting data for research sake, but it is about collecting data to enhance our knowledge of a given phenomenon, but it's also about using that knowledge to bring about change. And that change can happen through interventions, it can happen through policy, but all of it guided by an emphasis and a commitment to social change and health equity. Another important thing about CBPR, it is not a method. If you want to really get my goat, call CBPR method, and that'll get me. It is an approach to research. Any method that any of you have talked about and use, quantitative, qualitative, any research design lends itself, CBPR approach lends itself to using multiple methods, multiple research designs, and so forth.
Part of our CBPR principles, which are not on the slide, but it also involves co-presenting and co-authoring articles, which is why we're tag teaming up here. So some of our selected key principles, we have several, but in interest of time, we condense them and synthesize them into a few, is that it builds on community strengths and resources. So it doesn't just see a community of identity as a series of problems or diseases or issues, but also looks at what those strengths and resources are that exist in that community. Again, promotes the collaborative and equitable partnerships, including access to the resources, sharing of money, and the decision-making, and then balances research and action for the mutual benefit of all partners. So making sure that those who are most affected by the research are also involved in the decisions about that research, as Barbara said, from the beginning all the way through to dissemination. And then, as many folks have also already spoken about, there are a lot of health inequities within urban communities, many of which CBPR is uniquely positioned to address. So there's been a lot of recent data that shows that, especially for African Americans, that race and ethnicity, regardless of socioeconomic status, is the most important factor influencing health disparities. So really looking at that, and we know that there's a need to continue that kind of research so that we can uncover what are those factors that are contributing to those inequities.
And again, we would just say that CBPR really lends itself to looking at inequities and taking a social and environmental determinants approach to health. And so we were asked to talk a little bit about how CBPR links with the other approaches that this panel is representing. So I'm just going to say a few comments about that because you're going to get to hear from the other panelists in a minute. But urban planning also has a focus on community and stakeholder engagement. It also is informed and constrained by social and economic determinants of health, very consistent with the CBPR approach. Some of the difference with urban planning model, it often involves government. Using a CBPR approach, we often try to share our results with government, but they're not necessarily around the table in the research process itself. Health impact assessment, we actually use HIAs in our work using a CBPR approach. So the emphasis, again, is on assessing benefits and risk. One of the differences, HIA starts with a very specific policy or plan, whereas a CBPR approach doesn't start with that, but if you have a plan you want to look at, you can certainly use a CBPR approach with an HIA. The multi-level perspective, which we've heard about, the social ecological model, that informs almost all the CBPR studies, intervention studies, as well as basic etiologic studies that we conduct. And urban design, I think, has a lot to inform, and we use in our intervention work with its emphasis on facilitating physical activity, social interactions, making spaces safe. Again, how do we use urban design in the context of a CBPR approach? So a little bit about benefits, opportunities of using a CBPR approach. I won't elaborate on these, but I'm glad to do so if people have questions. First of all, it enhances the relevance and applicability of the research findings because it's tailored within the local community, culture, community context, language, history, etc. It ensures a focus and types of research that comes from, reflects the strengths of, and concerns of the communities involved. So rather than, again, myself as an outsider in the city of Detroit, I've been working there 30 years, I'll never be a Detroiter, I'll never really truly understand what it's like to live in the city of Detroit. The work that I do is totally informed by people who are in and of Detroit. CBPR also enhances the quality, validity, and cultural appropriateness of the research and the interventions, and therefore strengthens the confidence in the research results, that indeed we were asking the questions that are appropriate, thereby looking at the results and doing something with the outcomes that are relevant.
And then some of the challenges is that the CBPR approach requires long-term partnerships. This is not a one-night stand. These are partnerships that involve developing trust between the academic and community partners and managing all of those different relationships, the different ideas, different power structures, and then also balancing the need to do the research as well as action. A lot of times there may be something happening in real life that requires the data before we may be ready. So trying to balance all of those things. And again, we have a number of lessons learned that we would be happy to share later. Thank you.
Thank you.
I did prepare some slides at the last minute, so I'll just, because I was reflecting on why we're doing it. First, thank you for the opportunity. I think it's a great idea to have one meeting with one conversation along the whole day. I think I have, great respect and appreciation for that. And I've benefited from the previous meetings. That's why I think it's important to keep this conversation going. The reason, or what I'm going to raise here is health impact assessment. And the reason why I've been particularly interested and involved in that, is that there's a lot of knowledge that we have about the health impacts of sector policies, other sector policies, transportation, energy, housing, land use planning, on health, that we know that some of those things create risks, some of those things benefit health, but the knowledge, the way to systematize and to make use of that knowledge is not necessarily evident to everyone. And I'm thinking everyone who lives in a city not like Boston, but cities like in Africa or in Asia or in Latin America, which are smaller cities, and which do have health systems, do have public health people, who don't necessarily have the tools to make use of this understanding of the social and environment in terms of health and how they can contribute. So the end result is that we do detain a lot of knowledge internationally, globally. And I used to work for WHO, and that's why I've been involved and engaged and working on these issues, is that how do we make use of that capacity, which is enormous, the environment systems do not exist in every city in the world, or social institutions or social security. But healthcare or health systems and somebody involved in public health, they do exist. So how is it that we can make use of our international knowledge about the determinants of health and put it in the plate and enable people in all these places to make a difference, to avoid risks and to enhance the gains? And the thinking was stimulated by the Habitat Tree a few years ago, 2-3 years ago, where we were asked to produce as WHO what can health and health systems contribute to the new urban agenda, which was launched in, I think it was 2016. And this is a picture of Quito, where the conference was held. And what we've done was to take stock of some great experiences, including from healthy cities and other things which have been done, and to see what is it that within that context of intersectoriality, a health system should be able to do. And one of those things came out as health impact assessments. Why? And there's a few other things. There's a bit of history and a bit of economics, certainly a lot of economic methods, which I won't go through now. And I'll focus, because we have this understanding of where are the interventions in cities and the opportunities for action for health, which could not be perhaps used if we don't inform and we don't engage in those processes, leading to a number of health risks, proximal health risks, which we know more of in terms of health research, and looking at the health impacts. So the origins of health impact assessment is part of it is risk assessment, but this part is health promotion, and how is it that we do have a broader understanding of health determinants. And also not only the risk assessment from the point of view of the techniques of risk assessment, but how the political and administrative context are important to making use of that information. And the reason, this is a map of what the different steps in health impact assessments are also the same steps in environment impact assessment, in social impact assessment, in a family of impact assessments. And that's important because we are contributing with the unique information on health, but how is it that it relates to the other context of people who do understand of impact assessments? And one of the important things that is, it is systematic. So there's a way of going step by step and the things that you should be doing. You first, you consider what are the policies and the options and the opportunities that you have in your city, what's happening next, what are the things that people are going to invest, and so they don't make a bad investment, we can sort of make a contribution in terms of informing health. Then you screen to see what we know about in terms of the health impacts. Then you scope in the specific context, what is going to happen here, who's going to be possibly affected, where do they live, who's going to gain, who's going to perhaps lose from this. And then you carry out a more detailed impact analysis, which can be quantitative if you have enough data. And there's lots of modeling and agent-based modeling and other modeling that can be used, but it can also be qualitative. So it depends a lot on what you have at hand and how much you have in terms of data. Then you go into proposals for how do you mitigate risks and enable the positive impacts, how the other policies can do that and inform decision making. And then you should be able to use that frame to track results. Within that, you use a lot of science, but you build the frame for the analysis using the expectations that people have, the understanding of the opportunities and risks. And overall, what it provides at the end of the day is foresight. You're looking ahead into decisions which are going to be made, investments, planning decisions, transportation actions. And you're estimating what would be the potential impacts, positive and negative, and then how is that you can improve those. You're enabling trade-offs. Most people in cities are firstly interested in jobs and employment. Second, if you're a transportation department, you're interested in congestion. So how is it that health can be brought in and the health risks and benefits in the context of the concerns of others? It does provide accountability because you're indicating what are the health risks and benefits, so you're making it clear, transparency. It can be part of a regulatory framework, and there's all countries, or most countries in the world, even the very poor ones, have environment impact assessments legislation and requirements, which include health assessments as part of that. Now, it's not enacted because there's usually little competencies, little knowledge, people who cannot do that, but it's in the law. So you can use those mechanisms to make sure that the impact assessments are done, because that's the big question. We may do it in a few places, but the important to gain the benefits, to reap the gains, we have to be doing that everywhere. And then the context idea is that how is it that the local policies and local stakeholders, how do they see these policies, how do they see it, what they expect, and how do you frame the analysis taking those questions into consideration? So there's links with other approaches. Multi-level analysis are used. It relates directly to decision-making, to planning, to engagement of stakeholders and some of the limitations have to do with lack of access to tools, to knowledge, and capacity in all these places. So in order to make use of that, we have to be able to simplify and provide access, potentially electronic access to that as you do e-health for healthcare. You should be doing, PH health, public health access using some of these tools and knowledge. I think that some of the opportunities, apart from just enlarging and getting it everywhere, is actually to use it for communication purposes. So until the moment that we were able to really coin the soundbite and engage with different stakeholders around their concerns and explaining and engaging in conversations about what the health benefits of other sector decisions are there, until we have that capacity, we won't be communicating well. And I think for the process of engaging in health and health policies, it's granted to, I guess, it is a much bigger process. But in terms of what an individual health system, public health, capacities which can engage in this broader conversation, I think this is one of the key tools. So I leave that to the book, and I thank you for the opportunity for the conversation.
Okay. Good afternoon, everyone. My name is Oliver Gruebner. I am with the Geography Department at the Humboldt-Universität in Berlin. And I did this book chapter together with Layla McKay. Which one is the right one? Okay. So we are both no urban designers, but which I think might qualify us for this talk is that we are both with the Center for Urban Design and Mental Health, where I am a fellow and Layla is the director. So the Center for Urban Design and Mental Health is a global think tank on how to design mental health in our cities. So what is urban design? We consider urban design as the physical environment in urban areas, the public spaces, infrastructure, and building blocks. And as such, urban design provides the context in which social activities may or may not happen. And I base my presentation on the Mind the Gaps framework, which stands for Green, Active, Pro-Social, and Safe Places, which was originally developed by the Center for Urban Design scholars, originally in the mental health context, and for this context, we are adapting it to make it possible also in the urban health context. I would say this refers to the community level and the macro and public policy level, as Dustin introduced. So the first design approach would be to look at green and ecological targeted design, which relates to green and blue spaces. And we had a lot of conversations in the morning about that, that green and blue spaces, that is the vegetated land and water bodies, and they are well known to be associated with good mental health, or urban health in general as well. But as a geographer, I want to highlight that the green and blue spaces are part of a larger urban ecosystem, providing crucial goods and services to the public or the wider population in urban areas. So, for example, urban climate regulation, air pollution and noise reduction, fresh water and food provision, and opportunities for relaxation and restoration. So this larger urban ecosystem must be acknowledged by urban designers and urban planners, and its resilience strengthened especially in the times of global climate change. So this refers also to a systems approach as introduced by Daniel Ompert, as we have to look at it as an urban metabolism. Furthermore, I would like to highlight that there's a need to design activity in our daily routines. So an active spaces design, we need to rethink the urban transport system, the urban transport infrastructure by, for example, linking green and blue spaces across the city to increase the opportunities for active transport. And we also had that in the morning already for increasing the likelihood and the possibilities and options for walking, cycling, skating, etc. We would need to decrease the dominance of car infrastructure, which is clearly a passive transport, which all the known risk factors associated. And then this would bring opportunities to socialize and feel part of a community, which is also clearly linked to good urban health. Furthermore, there's a need for positive social interaction that helps promote belongingness, place attachment, social cohesion, and social capital, of course. So such a design would be needed for specific needs in the population, addressing equity. So, for example, children to play, socialize, explore, and as such, it refers to the community-based approach. So we have to do something not for the community, but with the community to identify the specific needs in the community. An example includes like the street infrastructure to host sport events, street furniture, bus shelters, flower pots, and so on to encourage people to stop and chat. And also includes building blocks with mixed land uses, facilitating spontaneous interaction. So with this slide, there are a couple of points to say, but I would like to particularly mention the last point here because this has been raised in the morning sessions. So this is about social sustainability, and this is not about that urban design needs to be social or sustainable, but actually the design should protect the social sustainability. So this refers directly to equity, and also to the health and all policy approach that Carlos just introduced, because we want to prevent side effects like gentrification issues when a neighborhood is improved in terms of new green spaces or whatever we like to introduce here. So we want to prevent from these side effects. And another thing is here that we like to stress that an urban design needs to be inclusive, so integrative and inclusive in terms of, for example, the mobility disabled, so that we not exclude anyone from an urban design here. And it, of course, needs to be safe. Delivering safety, preventing for traumatic experiences and accidents, but also we can design in healing approaches. And here I would like to provide you with two examples, particularly for a safety measure that is also fun. The Dutch city of Spijkenisse, and I hope I pronounced that correct, has just introduced the first Silly Walk crosswalk. For those of you who are still familiar with the Monty Python flying circus from the 70s and 80s. And this provides a safe and fun way to cross the street, actually. Another example is a community effort to restore normality after the earthquake in Christchurch in New Zealand. They have introduced a dance-o-mat, which is an old washing machine turned into a jukebox plugged with speakers where everyone can play their music and, well, dance. Conclusions for my talk today: urban design provides many opportunities for promoting well-being and health into our cities. I introduced the Mind the Gaps framework with which we could do that, actually, and it's important to incorporate both ecological and social sustainability. Thank you so much.
Thank you. My name is Helen Pinio, and I'm an urban planner from Washington State, but I've been living and working in London for the last 12 years. My presentation today will be very focused on the urban planning system and how it can be used to leverage urban health. So what is urban planning? Well, urban planners are tasked with addressing or trying to solve a number of societal challenges in the 21st century, dealing with an aging population, resource depletion, climate change, biodiversity loss, natural disasters, and of course, urban health and the rise of non-communicable diseases. But if you ask planners what is the purpose of urban planning, you will get a huge range of responses. And of course, organizations like the United Nations would say, well, it's about sustainable development. And doing that in a way that is equitable and efficient. But some planners would tell you, well, actually, in my city, it's about economic growth. So you have to bear in mind the kind of different perspectives and goals that different professionals are working toward. Urban planning contributes to many aspects of health in cities. And this diagram is a very simple kind of simplification of that that we used to explain to built environment professionals in a publication this summer. So we can see things like building materials, land use mix, food access, and a number of the points that have been discussed already today are directly influenced by urban planning policies and decision making. But some of the things that aren't on that flower include education or the provision of affordable housing, which is also directly influenced by urban planning. And as a result of those kind of wider influences, New York's Regional Plan Association estimated that urban planning policies and programs could shape up to 80% of a community's health. So it is a significant area to improve urban health. This diagram from our chapter in the book is really a simplification of the planning process, but it's helpful to understand in principle what we're doing. So if we start at the top of the diagram, we have evidence gathering, and that moves to policy development, over to implementation, then monitoring and review, and all of those stages are influenced by community and stakeholder involvement. And then outside of that system, we have a number of external factors like governance processes, environmental constraints, social and economic factors, and national or state policies that are influencing how the planning system works. And health can be injected into any stages in this process. So for example, at the evidence gathering stage, we would use information about either from urban health indicators or other public health statistics and reports about the distribution of health within a city, areas where we might need to focus our attention, our resources, so that policies would be health promoting. So the evidence should directly influence the policy. And the policy development stage is iterative and it's ongoing. And there's many opportunities for health professionals to be involved in suggesting improvements to policy through consultation. Again, at these two stages, community and stakeholder involvement is very important, and we can use approaches like the community-based participatory research approach to influence what we understand about communities' knowledge in terms of health and place. So policies in relation to urban planning will directly influence how we permit for new development and how we bring about new development and infrastructure in a city. I'll talk about in a moment that process and the implementation stage in a bit more detail. Then moving through to monitoring and review, we get a lot of help from our public health colleagues to understand the impact of our policies in terms of health. That information should then inform, become evidence and inform ongoing policy development, and we may need to adjust policies on the basis of that knowledge. Just to highlight that the system that I'm presenting links to a number of the other approaches that were mentioned in this session, and I think I've already highlighted them, but you can see the multi-level approach that Dustin mentioned feeds into evidence gathering and monitoring and review, and urban design and health impact assessment are very important in the policy development and implementation stages. For example, in London, we have health impact assessment required through the Greater London Authority's planning policies, and that would be for large-scale development going forward, but not all developments. So smaller developments would get missed out, and that can sometimes mean that the cumulative effect isn't really addressed. So this diagram, which I know you won't be able to see in detail, is from the chapter, and it shows the different stages of policy implementation in major development and minor development. And I can see that a couple of the words are missing on the top there. But the important thing I want to emphasize with this diagram is that there are many stages in the policy implementation process where health can fall out, but also where we can influence health. So if we think about a large-scale major development project, the concept and land assembly stages and the pre-application discussions, there's a lot of opportunity there at those early stages to integrate health. And as we go further into the process, things become more solidified and it's more difficult and costly to bring in those considerations. And if you think back to the diagram that I showed earlier of the planning policy process as a whole, those outside factors such as governance processes and economic factors can really come into play here in the policy implementation stage where, particularly on large-scale development, not all of the policies that are adopted in a local planning document will be realized on the ground. There's always compromises and there's always negotiation about what will be achieved. There are a lot of competing objectives for money and for space in urban environments. And so it's always a discussion about what can be achieved on a particular site in relation to the context and the local needs and the resources that are there. So this is an opportunity for health professionals to really integrate their knowledge and make a case at the earliest stages as possible as to the need to promote health through urban design and planning. And finally, I will just leave you with a positive note that I think we can all leverage urban planning to support health, and I would give you 3 takeaway messages to incorporate into your work. And I'm speaking to the audience as a public health audience. So those of you who are already working in urban planning and built environment, this might not be as appropriate. So make relationships with planners in your city. Build those relationships over time, build trust, and be on hand to answer their health research-related questions. The third point is to teach your students to do the same in their work as public health professionals. As we go forward, there are more and more people who have knowledge about public health and the built environment, but at the moment it's still a minority. So we have an opportunity as educators to increase the knowledge in this area and to make a difference going forward. Thank you.
Awesome. Are there any questions? Oh, we need some more. Hey, Carlos, come on. You can take this, darling. Okay. Oh, please don't fall off. That scares me. Any questions? Oh, boy. Oh, I can't see. Okay. Can someone get a mic? Or I can do my Vanna and jump off the stage.
Oh, thank you. Thank you. So, Karen Lee, I've done a lot of work on health in the built environment, and I'll be speaking about some of that later today. I have a question about health impact assessments, and also I think, if both Carlos and Helen, if you could address that, that would be great. So, when I got to New York City, I went up there from CDC, and at CDC, a big piece of work was on promoting health impact assessments. When I got to New York City, we certainly did do health impact assessments from a qualitative perspective, but we actually didn't have, working in the health department, the budget to actually do the quantitative modeling required for a lot of health impact assessments as they're done in many parts of North America. Early on, one of the calls that I made was to a university group that did such modeling and was told that it would cost about $400,000 for the initiative that we were thinking about. And so we actually redirected those funds to actually doing the interventions and then doing evaluations of them. So I wanted to ask, in terms of that balance of what's feasible, in terms of cost as it relates to health impact assessments, particularly the quantitative kinds, and how does that balance with the need for that data? Because I've heard, working with various health departments across the US, differing things on the effectiveness of health impact assessments in actually shaping policies. So, if the city or the municipality was not interested in moving forward that policy, then they would just poke holes in your quantitative modeling, right? And use that to derail sort of the policies that health might want to move forward anyway. So what is that balance, I guess, between the costs and efforts of actually doing quantitative modeling particularly, and how important is that in the planning worlds, Helen? So that's my question. Thanks.
Right. In terms of the expensive nature of health impact assessment, we do have a challenge in the UK context where there isn't a very good base of consultants who are able to do health impact assessment. And that's often where it would be done through the private sector. Organizations which are already doing environmental or social impact assessment would bring that into the fold of the work that they're doing. So there isn't really a good knowledge base there. So you get a huge range of quality in the health impact assessments that are coming back. And that definitely impacts how you can use that information for decision making. And planners certainly can recognize when they receive a low quality health impact assessment. But there is excellent guidance on the World Health Organization website and using different methods for health impact assessment, including qualitative and quantitative. I think it's important that we require a proportionate amount of impact assessment for the project that's going ahead. And a recent recommendation from our Public Health England organization said when planners are looking at green infrastructure policies, they should do some modeling on the impact of green infrastructure on air pollution. Now, that's not very feasible. So it could be feasible for a huge green infrastructure policy that's going to affect all of London, but it wouldn't be feasible for street by street, new street trees or green walls. And that was the recommendation, because they were saying, well, you can have positive and negative impacts, so you need to understand. So that, from my perspective, is a very unrealistic recommendation, and it's not very helpful. So being a bit more realistic about what a proportionate approach to impact assessment. But I do think there's a huge value, and there are resources available, which I'm sure Carlos probably knows all about, to inform the next generation so that we can get a better standard and make it easier and cheaper to do.
I'll give you a couple of examples. I think it's horses for courses. Sometimes you need a very detailed. One example, sometimes people can be taken to justice, to the court. I mean, I'm thinking of Florence, who was in Italy trying to implement public transport, and the Automobile Association took them to court, the municipality to court. In that case, there was a quantitative impact assessment of noise and air pollution and health risks, which was used by the court to give gain of cause to the municipality. against the Automobile Association. Then, so I think in some cases you have to go so I'm talking about access to justice, and I think this is one of the uses of health impact assessment. How is it that you can, and in India there's a number of examples of impact assessments, environment impact assessment, environment and health impact assessment have been used to take transportation in terms of improvement, requiring improvements of the fuel being used by bus companies, for example. So you can think of the justice system in a number of ways that people have used HIAs and EHIAs to create that kind of change. So using the justice system. There's a number of other circumstances that is probably enough to do some qualitative work. Another example is just Paris recently doing innovation, again, stopping parking in the city, providing less space for roads, etc. Again, being taken to task by a number of other stakeholders. So in those circumstances, I think you'll have to invest probably more on modeling and things of the kind. In other circumstances, I think you think of Tirana in Albania, where the mayor has been doing marvelous stuff on cities for children and engaging children in construction, the visualization of what the city would be like for them, early child development, that kind of stuff. He doesn't need a lot of HIA quantification to do that. He's actually using a lot of public engagement and children's engagement in that construction. So I think it depends on the circumstances. And yes, you won't be able to do the same thing everywhere, and you probably don't need to. And there are a number of international resources and examples that can use for people to borrow.
Yes, I know you didn't address the question to us, but I wanted to respond in that our organization just completed an HIA in Detroit in partnership with the University of Michigan and another community-based organization around the second international bridge that's being built in our community between Detroit and Canada. And we used community members to conduct door-to-door surveys, as well as the scientists did an excellent job of doing the modeling, doing the data analysis, but we were also involved in the interpretation. So we're collecting baseline before construction. There'll be some during construction, then after construction. But a couple of the huge benefits of using a CBPR approach is having community members who know the community, who have the trust of the community, who help gather that data, do the interpretation of that data, but also because putting pressure on the policymakers and the elected officials. The researchers do not live in the same area. They're not the constituents of the policymakers. Community members are. So we also conduct community organizing, put pressure on our elected officials so that they have to move to do those things. We wouldn't even have had an HIA if we had not been organized and putting pressure on our elected officials to begin with. So, but we also would not have had a very strong voice if we didn't have the science to back up what we were saying in our community. So that partnership is what was the strength in being able to push for the policy changes being informed by the research.
Thank you, actually, for bringing up the integration of CBPR with the Thank you.
Who funded that HIA?
Who funded the HIA? It was actually as a result of one of our community partnerships with the research. We were able to negotiate a $48 million community benefits agreement with the Detroit-Windsor Authority, as well as the federal government and the state government and the city, to be able to fund that. And we also worked in partnership with the health department. But again, it was that combination of research and community pressure to be able to negotiate that.
So there was a question before
Yeah.
you, sir.
No,
Sure.
health impact assessment has been on the agenda of Healthy Cities Europe for several years. 4 lessons learned. First, capacity is a big issue. It's easy to say that you can have a private company or maybe a big university in your town, but this is not the case in many places, and therefore they would not afford to do this. And other mechanisms, softer mechanisms, are important and valuable. Number 2, the choice of projects. There has to be some good thinking. You cannot really take every single project in your city through a health impact assessment process. You have to choose the most strategic, the more important, those which you suspect are going to have some impact on health. Third, and the most important, is that you have, if you get into this, you have to know what you're getting yourself into if you are serious, because you have to be prepared even to abandon the project, even to make substantial changes that some of the developers may not be happy with. So it's a serious business. It is not an academic exercise, especially if it comes from a political accountability kind of perspective. But the last point that I wanted to share with you is that we found through a process of health impact assessment, the cities found this as a learning exercise. It somehow ingraded the equity, the impact assessment, the social perspectives into their thinking. So when embarking on projects, they had to think beforehand about the process and the impact on health. And that was a net benefit from that effort.
Do you mind if I have a follow-up? I apologize. Hi, my name is Ryan O'Malley. I'm a member of the Malden City Council. Malden is a community just north of Boston. It's about 65,000 people. We have the Malden River. I've come to many BU public health organizations and symposiums before. I've talked about lead pipes, but now I'm talking about the Malden River. The Malden River had what was the predecessor of, I believe it's Hooker Chemical Company, that was made famous at the Love Canal. We've had GE on our river. Monsanto just down the river in Everett, which is just now being remediated by the building of a casino, a wind casino. We had the Converse rubber shoe factory. You might have heard of Converse shoes. So it's a river that's been abused. We are a community that does not have the resources to necessarily get the full chain back to the companies that have polluted. Many of them have played the shell game where they now have same board of directors, different company, you can't sue them. So what kind of in-kind or financial resources do communities like mine, Malden, have to really kind of take on this challenge?
So I know we're over time, but I'm looking at the organizers. Can we have a 1 minute of privilege? Okay, thank you. And I apologize for cutting you off, but I want to hear your question as well. So who wants to take that on?
You have the $150 million.
I knew that was coming out.
Well, I just wanted to give the opportunity to any of the panelists who hadn't spoken yet, if they wanted
Dustin,
to.
do you want to?
I can start.
I can go.
I just wanted to mention the point on the Malden River example. I mean, I don't know how you can get the money exactly, but one thing that might be useful that I recently saw, a nice example from New Jersey, was a citizen science project. So they had worked with students to measure the stream quality, and they had done that over a long period of time. And the benefit of that was, of course, learning and many things for the students, but actually they got the data, which rose awareness amongst parents, and that started to result in lobbying and advocacy to decision makers. And I think that might be, because it's lower cost than some other options, that could be a nice option for you.
In the EIA world, there's some provisions for having the industry to fund part of the it depends. I think the judiciary is important, is an important player, and what I've seen, at least in as well as citizen science, is the use of information. I mean, the public interest litigation using HIA in India has not cost a fortune, and it has led to important changes. So I think I wouldn't be discouraged by the fact that they are very powerful, etc. And I do think that both the community engagement and the use of strategic litigation, because courts don't necessarily respond to the letter to the epidemiological evidence. I mean, there's a view of what a judgment is made by a court, but they find enough evidence, which is perhaps not requiring a mathematical modeling of very high sophistication. So I think you have to take that into account.
We did a lot of community organizing and pressure over several years, and one project, I'll give you an example of what's called the White Cross Project. Every household in our community that had someone who died or who contracted cancer put a white cross on their front lawn, and then we got a lot of media attention. Just that visual was so powerful, it pushed people to do something.
Well, thank you all so much, and I just want to emphasize the importance of relationships, the importance of trust, and regardless of the approach you use, the importance of keeping equity forefront and center. So thank you to our awesome panelists, and thank you for allowing us a little bit of overtime.
So, two notes. I mean, one of the, in response to the last question, I mean, several of our faculty in our environmental health department are here, including our chair of the department. These are kind of informal conversations that might lead to projects, building on some things we've heard here. And one of the things we try to do in these meetings is to build in time for informal conversation. So now's that time. We're going to take exactly 28 minutes to get lunch, and we'll start again right on time at 1:30. Thank you.